IUI. It is a first line ART technique for couples who are experiencing infertility. We will be seeing which indications and all. IUI is minimally invasive, cost effective alternative to IVF, particularly for those couples who are having mild male factor infertility, unexplained infertility, or ovulatory disorders. However, appropriate patient selection is crucial to optimize your IUI success rate. And remember, this success rate typically ranges from 10 to 20% and not 70 to 80% what you are seeing on Facebooks and social medias. So you have to be realistic when you are counseling your patients about the success rate of IUI. And this success rate depends on patient's age, ovarian reserve, and sperm parameters, which we will be covering in details later on. So what are the prerequisites even before you recruit your patient for IUI? First and foremost, before IUI, there has to be ovulation. Of course, that is why we are talking about controlled ovarian hyperstimulation and trigger. Patency of at least one fallopian tube. Third, you should have an adequate number of motile sperms. We will be telling you about the minimum criteria of sperm parameters before you take them for IUI. And the fourth prerequisite is there has to be absence of documented or even suspected active cervical, intrauterine, or pelvic infection for obvious reason, because otherwise you will be giving them you will be transmitting this infection into the uterine cavity. So these are the tests to confirm the ovulation, which we don't do in clinical practice, our day-to-day practice, but you all should know. BBT we are not taking, but if you want to document, then you can do mid-luteal phase serum progesterone concentration, that is less than 2 nanogram per ml. Endometrial biopsy and all are outdated, but what we all doing routinely is transvaginal ultrasound. So if you are serially monitoring your follicle, you will come to know that this has ovulated. I will tell you the features of ovulation when I am covering the monitoring. Now coming to the age of the woman. Among all the patient parameters which affect the IUI success rate, age of the woman comes first, because with increasing age, there is a declining in the oocyte quality. And not only IUI success rate, even our IVF success rate is related to age of the woman. There are many studies. I have quoted only very few studies where they have documented that after the age of 40 years, IUI does not seem to be a good option for these women. And if she is between 35 to 40, her success rate are definitely lower as compared to the woman who is in her 30s. So accordingly, you counsel her, give her realistic success rate and take her. These are the semen parameters. There are several sensitive indicators with respect to different sperm parameters which determine the prognosis of IUI, and sometimes whether you should take this patient for IUI or not. Though there is no overall consensus on the cutoff, most studies have determined impaired success rate in the following scenario. That is, if total motile sperm count is less than 10 million per ml, normal sperm morphology is less than 4%, inseminating motile count. Dr. Kersey will tell you in great detail what do we mean by inseminating motile count. If it is less than 1 million per ml, and rapid progressive motility post-wash, if it is less than 25%, then your IUI success rate declines. The third factor which affects your IUI success rate is the etiology. That is the indication for which you are taking this patient for IUI. This is the large Indian studies, and they have given you success rate according to the etiology. So if it is ovulatory disorder, the pregnancy rate is 21, around 21. Tubal pathology, 11%. endocrinological 13, unexplained 11, male factor 14, combined both male and female 51. So in general, again I am coming to the same point. The IUI success rate is per C 14, that is 15 to 20%. Cervical factor is the most rewarding indication of IUI, but we really get a pure cervical factor case for IUI. In this case, you can expect the success rates to be as high as 50% because you are just bypassing the cervical factor. Rest all is normal, both male and female, and this patient has high chances of becoming pregnant. The second etiology for which we take these patients for IUI is minimal and mild endometriosis. In selected cases, you can even take moderate, but in moderate endometriosis, if AMH is too less, we do go for IVF. So for minimal endometriosis, pregnancy rate of 21% and mild around 18.9% has been observed. What about unexplained infertility? Unexplained infertility, we all know these are the older studies, thereby everywhere you will see clomiphene citrate, but now letrozole has become the first oral ovulogence when it comes to stimulation protocol. So oral ovulogence is the first line for treatment, and if your patient does not become pregnant, the ASRM tells us to skip the second line, that is gonadotrophins. The ASRM is telling us in cases of unexplained infertility, if oral ovulation cycle at IUI fails, you directly take them for IVF ICSI. How many cycles they are recommending before you are taking them for ICSI? Not more than 4. Don't go on doing. Even last month, I got a couple from periphery. She had undergone 22 cycles of IUI and I just could not believe. But patient was very well educated. She showed me all the papers that month after month she was going for IUI. Now she got fed up. Her AMH is 0.5 and now she has come for IVF. So how many cycles? Maximum 4. If your patient does not become pregnant in 3 to 4 cycles of IUI, please take a pause, reevaluate, reassess the case, see what you have missed or why your patient is not responding, and accordingly take the next step. Does body mass index matter? Because nowadays we are seeing more and more patients towards higher side of BMI, or we are getting very lean and thin patients. So you have to know, all the studies are saying BMI per se does not affect the success rate of IUI. But you have to counsel her that if BMI is higher, she is more prone to have obstetric complications. So there is, you should not deny them IUI, that is infertility treatment, provided you have counseled them about the obstetric implications of high BMI. So now coming to the indications. What are the indications for IUI? Because the coitus is avoided when you are recruiting them IUI, it is useful in couples with some sorts of sexual dysfunction. Now we are getting more and more couples, especially IT couples, those who are having stress factor, their bedroom life is haywire. So they are having ejaculatory dysfunction or sexual problems. So IUI is good for them. It is also good for the discordant couples, those who are having STIs or HIV. For cervical factor, mild male factor, also you can take IUI as an indication for women who are having ovulation problems in cases of unexplained infertility, minimal or mild endometriosis. So if you want to tell you in nutshell about the indications for IUI, you can divide them into male factor and female factor. For male factor, it is related to ejaculatory failures, whether it is retrograde ejaculation, hypospadias, impotence or infrequent intercourse. Now long distance marriages are also very common, and if you are doing donor insemination. For female, cervical factor, mild endometriosis, unexplained infertility, vaginismus and discordant couples. Donor insemination, if she is having azoospermia, but don't jump. The moment you see zero sperms, don't jump and advise them donor insemination. You have to repeat the semen sample. At least 2 samples should show you the zero sperm count. Send them to an endocrinologist, whether this is an irreversible cause of azoospermia or reversible cause of azoospermia. Some cases are reversible by the management of this andrologist. Then, if it is irreversible azoospermia, then also whether you can take this patient for TISA or really she is a case of donor insemination. Because the sperms might not be there in the semen sample, but testes are producing. And every couple, it's a very, very sensitive issue. Everybody wants their own child. So give them option. So azoospermia, second sample, reversible or irreversible. Irreversible, whether she can go for TISA or she is not eligible for TISA, then only go for donor insemination. You can also do donor insemination in single woman and same-sex female couples. This is in ART Act, it is allowed to them. When you are telling them about the donor insemination, use only cryopreserved sperms. Gone are those days when you used to phone the persons who used to supply the semen samples and they used to supply the fresh semen sample for donor insemination. Don't do that. You have to acquire this sample from a registered ART bank. Like I am ART clinic, level 2 ART clinic. So I have taken the certificate of ART bank for my records from where I am procuring the semen sample for donor insemination. So have one copy of their certificate in your record. And you have to preserve this record for 18 years till that child becomes major. These are the contraindications of IUI, that is cervical atresia, cervicitis, moderate to severe endometriosis, bilateral tubal block, and severe OATS, that is oligoasthenoteratospermia. Now, once you know the indications, counseling per se does not affect your IUI success rate, but you have to give great length of time in counseling, not only women. Counsel them as a couple. Insist that your husband has to be here and you do couple counseling. Mother, father, in-laws are most welcome. But the most important persons who should be sitting in front of you are husband and wife. So you have to tell them why you have advised IUI, what is the procedure like, what is the success rate, how many cycles you are planning. Tell them in the beginning. The cost, what are the complications, and bed rest, whether you tell or not. Their immediate query will be, डॉक्टर कितने दिन छुट्टी लेना है, मुझे जॉब से 15 दिन छुट्टी निकालनी है क्या, घर में मेरा करने वाला कोई नहीं है, सीढ़ी ऊपर नीचे चढ़ना पड़ता है, मैं सीढ़ी चढ़ सकती हूँ क्या. I really don't know what they read on social media, but everybody has got only one query, bed rest लगेगा क्या. So you address all these concerns in the counseling part. And of course, ART Act, if you have gone through, they have given you the consent forms. Download those forms, have it on your letterhead, and take consent accordingly. Now comes the pre-treatment workup. How you will start? Of course, it starts from the history taking. In great detail, you will be taking menstrual history, obstetric history, previous treatment history. Sometimes वो इतना बड़ा गट्ठा लेके आते हैं कि बहुत जान पे आता है देखने को, पर एटलीस्ट एक मोटा मोटी देख तो लो कि कितने IUI हो गए हैं, किसने लेट्रियोजोल दिया है, किसने कितना CC दिया है, किसने क्या किया है. एक जस्ट go through all those records. Ask them the history of diabetes, hypertension, thyroid, the history of medications, family history, coital history. And I always ask them कि और कुछ बताना है आपको. And sometimes we never know and they tell you something relevant, but we have not thought of, or it is not there in our history sheet. Then starts the examination. Start taking height, weight, because we directly do transvaginal ultrasound whenever any infertility patient comes. Sister के पास जवाबदारी दे दो, height, weight, BMI लेने का, जनरल एग्जामिनेशन डोंट फॉरगेट टू पुट एटलीस्ट स्पेकुलम वंस हर बार करने का जरूरत नहीं है, पर एक बार तो पर स्पेकुलम पीवी एग्जामिनेशन करो, उसके बाद ही do your transvaginal ultrasound, preferably on day 2 or day 3, so that you can do antral follicular count and you can have a look to the whole pelvis. You can see the uterus, you can see the ovaries, you can see whether she is having hydrosalpinx, fluid in pouch of Douglas, whatever. So then comes the transvaginal ultrasound. Now comes the blood reports. Patients आते हैं भर भर के सारा reports लेके आते हैं, FSH, LH, testosterone and what not. इतना सारा हार्मोन रिपोर्ट्स का जरूरत नहीं होता है. Don't put an extra cost burden onto the patient. What is must is CBC, blood group, AMH. Yes, I have written it in a must because you should know what is the ovarian reserve even in a 25-year-old woman. Prolactin is must. TSH is must. Then case specific hormone test. Even in PCO, these hormone tests are enough. AMH, prolactin, TSH. That tells you everything. And HPLC, because we are practicing in Vidarbha belt, sickle and thalassemia is common. So it's better if you can do HPLC or at least inquire. Many of them, they do know that unko sickle cell trait hai, thalassemia trait hai, whatever. Now, whether you should know the tubal status beforehand when to take them for IUI. This is the guidelines. That if the clinical history is suggesting the tubal pathology, like if she is giving you history of prior DNCs, if she is more than 35 years of age, but in clinical practice, it is must that you should do HSG before you recruit them for IUI. आपने 3 IUI कर लिए, उसके बाद I am only telling you to take a pause. You are taking a pause and then telling her to go and do the HSG. She comes with bilateral tubal block. Imagine the scenario in your OPD. You just can't face, you just can't answer. So better hai, guidelines are guidelines, they are there to guide you. It is not mandatory to follow the guidelines word by word. So HSG I do in all my patients before I take them for IUI. Semen analysis must. We have told you what should be the semen parameters before you tell them to go ahead and you will do IUI for them. So from my first presentation, that is patient selection and pre-treatment workup, I'm sure you all must be now very clear what are the indications. What is the pre-treatment workup from history, clinical examination, lab test, HSG, and how to do counseling on them.